Breathing in diesel exhaust fumes is like walking into a fire without a mask. Over time, those toxins lead to cancer. Protect yourself with MagnaGrip, the easiest, most reliable exhaust removal system that features a true 100% seal to eliminate diesel exhaust fumes. To get free grant assistance, visit magnagrip.com.
Hello, everybody. I'm Dr. Beth Murphy, and if you've listened to any of my shows, you know who I am. For anybody that hasn't listened, I am a retired firefighter, and I'm a psychologist in private practice now. And I'm married to John Murphy, and some of you may have heard him. He's often up and talking about legal stuff affecting the fire service with a few of the other guys, Kurt Verone, Brad Pinsky, and Chip Comstock. So they're a lot of fun. Sometimes I listen to them and I think, oh, that would be a great topic for psychology. And it's really interesting how much what comes up in the legal realm has some pretty significant psychological components to it, put it that way. But that actually is not what I'm going to talk about tonight. As usual, I couldn't decide what I wanted to talk about. And so I thought about like conversations I've been having this week and just kind of stuff that has been coming up. Stuff that comes up like for me personally and stuff that comes up for other people that I talk to. And there was a couple things, and I'm hoping that I can mesh them together well enough that it makes some sense and will be useful. So the first thing that came up was I was having a conversation with the medical doctor at the Station 2 clinic. So they do all the the 1582 annual medical exams, and so we'll have these conversations sometimes, and I like talking with her because we think alike, which is it's kind of nice. So we often will see eye to eye, and we see some of the same problems or issues or things that we would like to improve on. And so we were having a conversation about a particular treatment center that somebody had brought to my attention. So it's a treatment center for like trauma and substance use and abuse. And so we were talking about that particular program. So most treatment centers are, like 30 days. And then they will recommend extending it, by 15 days or 30 more days or whatever. And this particular one has a minimum of 90 days. And unfortunately, there are some people that I can think of, or, people I've heard of, that would definitely benefit from something like that. So it's like, and this particular treatment center, they talk about how the first 90 days is like foundational, and it's kind of where they get at a lot of the stuff that's driving the mental health symptoms, and then teaching and reinforcing a variety of different coping strategies, and then they're addressing like nutrition and physical health, like working out, being outside, socialization. I mean, all the things that are important to be healthy overall. And the doc said, it's just sad that they have to get that bad, and that we need to stop them. We need to intervene before they get that bad. And that really is like what we're trying to do when we're talking and we're trying to build a program where they're addressing the physical health, but also the mental health. And so right now, a lot of it is interventional. And so, I hope eventually that we can move more into a prevention type field. Of course, deal with what may come up if somebody is really struggling and they meet, one of these mental health diagnoses. But, my goal ultimately is to get to the point where we're being proactive, where we're providing preventional tools, and then we're catching and helping people sooner if they are not able to help themselves. So I would like for us to get to a point where they're not going to a 90-day treatment center. Not like I really want to put them out of business, but yeah, I think I do want to put them out of business. And so this is a struggle. It's a constant struggle, and I have to say that I think that we've moved forward a little bit. So that was one side. So that's one conversation. So it's about trying to get to people before they get that bad, before they're bad enough that they need to go away to a treatment center, especially one that is a 90-day. There's benefit in that, but they still have to come back and reintegrate. So that was one conversation. And then the other conversation that I had this week, and I guess in some ways it pertained to me, but definitely to, everybody I work with. And that is, how do how do you identify what mental health disorder is somebody struggling with? Like, there's so much overlap, and so there's a lot of overlap, and then there are some very distinct differences. And even people in the profession meaning mental health, if they're not expert in the area and they're more like a generalist, they don't always get it right. And so, the two areas that I'm expert in is in trauma, acute trauma symptoms. So acute post-traumatic stress. I guess it's like, technically you could diagnose PTSD acute, but that's, some people pass right through that, like they experience it, but then they get better on their own and they never get a diagnosis. So, I think anything that is acute, it actually fits better to call it an injury, which is something that is being pushed for in many of the fields where they do deal with a lot of people that are potentially, where they're exposed to traumas and potentially dealing with post-traumatic stress symptoms. So anyway, trauma, PTSD, and then ADHD is, these are areas that I am expert in. And so I will often see, I will see ADHD quite a bit in firefighters. And, some people will think, well, you struggle with it, so you see it in everybody else. And it's like, well, I suppose that there's truth in that. But sometimes what comes to mind is like, it takes one to know one sometimes. And it's like, the more I learn about it, the more I see how it manifests. And that's true of like any of the trauma related diagnoses. So, so it's like, so now I'm talking like I have two different tracks in my head right now. So one is about the overlap, the similarities, and the distinct differences of each mental health disorder, and particularly the ones that we might see in the fire service. And then the other is, kind of moving things into the place where we can move away from um, the intervention and get more into like a prevention, or at the very least to catch people sooner. And so I think like in my brain this goes together very well, um, because I want people, one is to recognize when they're struggling sooner, and to be okay with asking for some help if you need some help and some guidance, but also to help educate them so that they can maybe direct their own care a little bit when they do seek out a provider, um, and and then ultimately to recognize the difference and understand what they might be treated for, and what might be appropriate to treat first, because that is an area where sometimes I differ from like a psychiatrist even, because they may focus on something else and overlook what I see as being the real issue. So, so that's kind of what's been swirling through my mind a lot. So, well, and then it's like, and then I've seen a lot of firefighters with PTSD, and as they're talking and I get to understand them and learn about them and learn about their history, I start to see like, oh, maybe they have ADHD. Now, this is the thing about ADHD is that and I should say, so that's attention deficit hyperactive disorder. And it's not the most accurate name for what it is. So it has been proposed that the name be changed to variable attention to stimuli trait, because it's not that people can't pay attention, it's just that they may pay attention to something else. So they have variable attention. Um, and the interesting thing is that the symptoms that we identify in ADHD, um, they can look a lot like what is identified in PTSD, also in depression, also in anxiety, also in like an acute stress reaction. So pretty much anything um, that affects you, it can potentially affect your cognitive functioning as well. And so this kind of overlap and what I've been seeing has like kind of stuck in my head quite a bit, and also how, because I do deal with a lot of firefighters that are filing worker comp claims, when they go to like their their normal doctor or a therapist, and this is not true of all therapists, but um, I've seen it in some, like if they're more of a generalist, they will listen to what the firefighter is saying, and then they will also often offer up a diagnosis of like depression and anxiety. Well, depression and anxiety um, is also a huge component of PTSD. So, um, and there's, those are uh, potential differential diagnoses, or they can be comorbid, meaning that the individual can have PTSD as well as depression and anxiety. Um, and it would be more likely that depression would be present than anxiety itself. In fact, PTSD used to be classified as an anxiety disorder. And they changed that in the recent diagnostic manual. So when we moved from DSM-4 to DSM-5, they moved PTSD out of the anxiety disorders. So it's like its own separate category as an acute. It's an acute response to traumatic stress. So and then as symptoms persist, then it can shift to PTSD. So the problem is that there's so much overlap, and because there's so much overlap, and people may not know the differences, some people can get misdiagnosed, and it doesn't always mean that when they have PTSD, they're misdiagnosed with depression and anxiety. Sometimes they're diagnosed with depression and anxiety, and they all their their treatment and interactions with mental health professionals are along those lines. And this is glaringly important when somebody gets diagnosed with PTSD and they file a worker comp claim and it gets denied, and then they're having to fight for it. And then the opposing party will bring up, well, you were diagnosed and treated with depression and anxiety, and now you're saying it's PTSD. And it's like, well, it was PTSD all along. It just didn't get appropriately diagnosed. So what do we need to know about this? I'm like, what can I tell you that will help you so that you can be somewhat educated about this, so that you can be a better advocate for yourself? Because this is an area that honestly is difficult for mental health professionals. I mean, if it wasn't, then we wouldn't have a lot of misdiagnoses. It's not like we can take an X-ray and go, oh yeah, right there, I see a little fracture of PTSD in there. And it would be wonderful if we could do that, but we can't. And the problem also is that a lot of times individuals that are struggling, and maybe they are just at this kind of lower level where they don't meet full criteria for PTSD, but they are in fact experiencing more of a kind of a depressive episode, or maybe I see a lot of like an anxious depression. It's pretty rare to see just anxiety. Usually there's something else going on with it. But it's like if somebody was performing, living, and they were just fine, and they didn't have a history of depression or anxiety or PTSD, then that person potentially could experience a lot of stressors, traumatic stress and day-to-day stress, and have some symptoms that are part of PTSD, but maybe more so of depression. And in that case, they may end up getting diagnosed with depression, or they may not get diagnosed with anything because this kind of creeps up. It's a slow, insidious process often. And it's not until somebody else brings it to their attention, or they start struggling with something at work or at home. So it's like if they are meeting criteria for something like depression or anxiety, it's like it would be better to get them help at that point. It would be better for them to reach out for help at that point. But also recognizing that if the depression is brought on because of what they're experiencing at work, it is probably more likely that that is an acute reaction to traumatic stress. And so while it may not be PTSD, it would be like a, well, it's a, I always forget the diagnosis. For the longest time, it was PTSD NOS. I think it's unspecified now. So you could have a PTSD unspecified, and that just means that you're experiencing some of those symptoms, but not all of them. And honestly, I wish there was a different way to talk about it, because I don't like referring to it as a disorder. But we do. And that's the language that we have. It's like, that's the common language. So it's, the fire service has its language and its terms for its equipment and the apparatus, the tools, the calls, the actions they take. It's the same for mental health. So we all our language is around disorders. So with that said, it's like, well, what do we really need to know? So I think, to me, it kind of makes sense to maybe work backwards a little bit. So I'll start with PTSD. That seems to be what people are most familiar with. I mean, it definitely is what is written about and talked about most often in the fire service. I have some feelings about that, and that I think that it has contributed to this idea that you can't get help unless you have PTSD. And I think that helps feed into why people are waiting so long before they do get help. But that's my opinion, and maybe one of these days I will write an article about that. But right now, it's just something that just floats around in my head. So back to PTSD. Well, first and foremost, to get diagnosed with PTSD, you have to experience in some format a traumatic event. And there are the DSM-5 defines what those traumatic events are. So it doesn't include all of the potential events that do contribute to PTSD. Like the ICD, I think we use the ICD-10, but I believe that the rest of the world uses the ICD-11. I think that's in effect now. They recognize interpersonal traumas as contributing to PTSD. So it's like they take that, they take it a little bit further. So people who are bullied or harassed in any way, discriminated against, it's like they often will present with the symptoms of PTSD. And if that is the case, I can't diagnose them with PTSD, or I can't attribute their PTSD to the interpersonal trauma, because the DSM-5 doesn't recognize that. And so also the people that may be determining whether this is something that's work related or not, they don't recognize it. So if the DSM-5 doesn't state it, then they don't recognize it either. But those interpersonal traumas that come along with discrimination and harassment, even at a low level. So with any mental health disorder, there, the development of it is a function of particularly PTSD, frequency, duration, and intensity. So you can have, one event that is of a long, intense duration. So long duration and very intense, and that could contribute to PTSD. You could have a lot of events that are kind of low level, so like when we think about interpersonal traumas, it's like a constant exposure to what we call microaggressions. So it's those little actions and statements that can cause a person to have to expend a lot of energy to interpret it. Um, it's like these little jabs and little put downs, and they're often hidden by oh, hey, I'm just joking, that kind of stuff. I mean, exposure to that constantly, so you have like high frequency but low intensity, um, and duration. It's not that it has like one constant long duration, but it's like if you're frequently experiencing it throughout, the course of all year or more, then that can lead to development of PTSD. So anyway, but the back to like the traumas. So it's like most of the traumas that they recognize would fall under like it's part of your job. Um, it could be like natural disaster, it could be a fire, it could be any, like violence, either witnessed or directed towards you. And that's something I've heard a lot is because a lot of the calls, like Seattle definitely, but a lot of the departments, and I'm sure this is true across the country, there are a lot of homeless individuals, and then also substance addictions and overdoses, and so there is a lot of violence that is perpetrated by some of the homeless people against the firefighters who are there to help. And so that's part of the job, but it also is something that happened to them. And then, yeah, there could be, like for military, so like military, seeing combat, being a POW, that's one section also. So anyway, but it pretty much is any of those traumas that potentially would cost you your life in some way, shape, or form. And then it can be something that happened to you. It could be something that you witnessed happening. Like watching a vehicle in front of you get, like smashed to pieces, and then seeing what happens to the passengers. It could be like learned about it. This is something I know affects a lot of fire departments, is like when you lose a member of your department. You didn't have to, know that person closely, like, they may not have been your best friend, but it's somebody that you knew. And then you find out that they died in some way. This is something that I've dealt a lot with here locally, because there have been, and this would be for any department across the country, is like, when one department loses a member, and it's somebody that is like part of the larger, teacher training community, it like their loss can affect a lot of different departments. And so losing somebody like that, that would be a learned about unless you were actually with that person, and then that would be a witness. And I already had said, it's part of your job. And it's like the learned about it part is not like watching it on the news. They made a distinction about that. But I would say, like, if you think back to 9/11 and those events, I remember being up and getting ready to go to work, I was going on shift, and that event and watching it on TV, it's like it had a profound effect on every firefighter. So I think that even though they say it can't be something that you have seen on TV, I have no doubt that things like that have an impact. That's why when somebody's struggling, I always tell them, well, don't watch the news. So I don't watch the news. I watch it once in a while when I think I need to know what's going on. But when I've heard people's stories all day and heard what they've gone through and how they're impacted and how they're struggling, it's like I don't want to watch the news. I used to watch horror stories because I liked that. I liked, activating my alarm system, and I don't do that anymore. It's like I don't need to do that. Um, so I recognize that those things are not helping when I'm trying to calm down. And so I will advise people don't watch TV. So anyway, but back to the symptoms. So the trauma part, it's like that's part of the job. Whether you are recognizing the particular traumas that you experience or not, it's like it's part of it. It has an impact, whether it's the biggest impact. Um, I don't know. For some people, it is. For some people, it's not. For everybody interprets the traumas that they experience a little bit differently. We all have a different standpoint, and that affects how we interpret things and and then all our experiences in the past inform how we manage what goes on today and how we're going to manage happens tomorrow. So all of this is like very unique for each individual. And so there's common language around it, but what that might look like could be different, and how the person experiences it can be different. So the symptoms, so it's like you have the trauma, and so now the symptoms that you might experience, and most people know there are like intrusion, re-experiencing symptoms, avoidance, alterations in cognition and affect, meaning cognition is your thinking and how you process things. So there can be some issues with how you think and process and make decisions. And then mood, we see a negative mood. I mean, if you don't experience a negative mood at all, then it's likely that it is not it's like you may have some symptoms of PTSD, but without that, then you likely wouldn't meet that full criteria. But most often, by the time somebody comes to talk to me, they have experienced a lot of negative mood. They will often talk about how angry they are or irritable, how they don't have patience. And it may be that they recognized it, but most often it's somebody in their household, like their partner or a child. And I remember a story from FDIC a while back, and it was one of the which is really funny. It's like I can't remember who had told me the story, but it was someone that is pretty well known in the fire service community. And he had told the story about his own struggle with PTSD and coming, face to face with it and having to do something with it. And he said that he didn't see it. And that's the thing, is that it comes on really slow. It's not something that you experience all at once. It's not like you broke a leg, like, when you broke a leg. So it was this kind of slow, insidious process. And one day I think it was his daughter, um, who, little girl looks up to him and says, "Why are you so angry, Daddy?" And that was it for him. Like he knew, and there was no more denying it. And that's often how it comes around. Sometimes people lose everything before they come around. Like they lose their marriage, they lose their house, they lose their relationship with their kids, they lose their financial stability. Like they might still have a job, but if they go through a divorce and they're giving up their house, they're pretty much giving up, half their pension, or whatever, however long they've been married, and so they lose a lot, and it's not until that is it recognized. Um, well, I'm going to back that up. It's like it may not be recognized at that point, because again, people who aren't expert in that and don't understand the fire service, they might see this person and diagnose them with depression and alcohol use disorder and maybe anxiety, because they don't understand, the firefighter. They don't understand that when you experience something that shakes you to your core, whatever that is, you're not talking about it. You don't immediately go and tell somebody, "Hey, I'm really struggling with this." I did. I'm a talker, so I work things out verbally, and so I talked. But I was lucky; I had my husband who was in the fire service, and I could talk to him, and I could pretty much say anything. Now, the fire service I was in, and the fire service he was in, there was a big difference, because of like when he got in versus when I got in, and then him being a white guy, me being a woman. We definitely had different experiences, but there's like kind of these larger commonalities, and so it was enough where I could talk, and he listened, and he got it. I mean, and even when it involved like discrimination, and I mean, not so much, I would say, harassment. It was more like discrimination. Like he took the time to listen and to try and understand from my perspective. And I give him a lot of credit for that, because when you haven't grown up as a woman, it's hard to really like put yourself in their shoes, so to speak, and experience what that's like. But he tried really hard to do that. And so I really appreciated that. So it helped me a lot to be able to talk. Um, it's like, I think like because I was talking, some of these symptoms would have been made more obvious, if they were present and they were persistent. So, like the alterations in cognition and the negative mood, he would have seen that and heard that, but I would have been talking, and because I was talking things out, I would have heard myself say that, and that's like one of the reasons why I kind of talk things out. The There can also be, and this is an interesting one, it's like an ability to remember important aspects of the traumatic event. Sometimes I think I had somebody tell me when we were doing an assessment, they're like, "How could I remember what I don't remember?" And I thought that was kind of funny, but it's like sometimes people will like remember the event differently. And so, regardless of what you feel about, CISM and like doing a diffusing or a debriefing, I think one of the benefits of that is that when you come together and you talk about the event, you get to hear different perspectives of that same event, and and you may hear something that, like you were part of that piece of the event. And so it kind of helps put the story together, because if the brain doesn't have all the information, it will make stuff up. And so it's like, you may think you remember all of the event, but what you remember is the part that you were involved in, and then the rest of the story that your brain made up is often what that means. And then sometimes people are like, I don't remember. I mean, I shared with you my experience, like with my seizure, and then having the tumor and the surgery and all that stuff. It's like, there's a lot I don't remember. And it's something that, like, my brain's constantly going back to, like, look at it and go, why don't I remember? And I'm trying to just accept the fact that I don't remember. So, um, so it's like, I'm trying to be okay with that, but my brain wants to know. So, and all it can do is make stuff up, and I'm telling my brain that that's not okay. Um, but so negative thoughts and feelings, and then distorted beliefs. So I've seen a lot of people develop, like, almost, I mean, I don't really like this term, but it often is one that gets thrown out there, but like a paranoia. So they can get paranoid, like people are out to get them. The department is out to get them. And, I hear some, think about it on a continuum, and I hear a lot of this, like, kind of played out like at a lower level, the lower end of the continuum, where the common statement is, the department doesn't have my back. It's like when they started their career, that they didn't go into the fire service with that attitude. And it is true that there are leaders in the fire service world that they're probably not the best leaders, and maybe they shouldn't be the chief of the department. But whether they are or aren't, someone who's struggling with PTSD will start to feel like they're not good leaders. They're not supportive. They don't have your back. I mean, that could be like anywhere from, like, your officer all the way up to the chief of the department. And it doesn't mean that there's not truth in that, but it's definitely skewed by the experience of PTSD. So the person's worldview is changed. And so and then there's a lot of blaming, and it might be blaming themselves or blaming other people, not for the event, but maybe kind of what happens after, because it often isn't the event. It is what happens after. It's how you deal with it after, how you look at it, how you interpret it, how you process it. And then along with that can be, the loss of interest in activities, the like anger, fear, horror, guilt, shame, sometimes hopelessness, helplessness. And that was interesting, because, like, they changed the definition of PTSD. In DSM-4, it used to include that sense of helplessness, and they changed it. They took that out, and I remember at that time I was like, yeah, I don't think firefighters would admit to PTSD if it meant like acknowledging that they were helpless. And I couldn't be more wrong. I have heard a lot of people talk about how they feel helpless, and it's mostly about feeling helpless, related to, like, not having control of the situation, not having control of the aftermath. It's like things are happening, and they feel like they can't do anything to intervene in that. And I've heard that a lot. So I'm like, I think you could probably put that back in. And then feeling detached from others, and not being able to experience positive emotions. Now, a lot of these that I just said, it's like these are present in depression as well, which is where we start to, we're starting to see that if you don't really know about trauma and PTSD and about the fire service, then you can see that somebody's going to be diagnosed with depression if they're experiencing some of these symptoms. And then the last one is like the hyperarousal piece. And so that is, that may be like, that is like irritability, having angry outbursts, behaving recklessly, we often think about like being watchful and on guard, for, like something that's going to go wrong or something that's going to happen. Having problems concentrating, which is, it's like we already have this alteration in cognition, but now we have this like hyper arousal piece that also contributes to difficulty with concentrating. And then problem sleeping. And it's like, if you're not sleeping, then all these things get worse. And there's a lot of kind of like body reactivity with this last one. And then like kind of this fear or foreboding. So this is stuff that you can experience with depression and also anxiety. So there's a lot that goes into this, as far as like, what those signs and symptoms might be and how they might play out, how it might look in people can be different. And then how they get diagnosed when they do go get help really depends on like what the most prominent issue is. Or well, and of course the expertise of the person they go to. So now I'm going to move to depression. And so the symptoms that we see in depression, the first thing we think of is like feeling sad or depressed. But sometimes people don't feel sad or depressed. They feel nothing, like they feel flat, they feel empty. That's something I've heard from people with PTSD, because it's like if you're experiencing something that is intolerable, then you might shut down because you don't want to feel it. You don't want to feel uncomfortable. And it's part of our survival mechanism to avoid what doesn't feel good. So if we're experiencing things that doesn't feel good, then our brain is going to react to that, and it might shut off feelings, and so then you become flat or empty. Loss of interest or pleasure in activities once enjoyed. That is in PTSD as well. Like, you pull away, you don't interact. It's like you don't have energy anymore. You don't have that interest. Change in appetite, weight loss or gain, trouble sleeping, loss of energy. I hear a lot about loss of energy and sleep, and fatigue. I mean, it's like that's kind of part of the job. If you're running, I don't know how many calls during the night and you're not sleeping, of course you're going to be tired. And being tired is like probably one of the most prominent symptoms of depression. And because depression feels low, it feels unenergetic. And so, anybody who's experienced depression and recovered, when they get tired, it would be normal for them to immediately think, oh my gosh, I'm getting depressed. And that's not the case. You're just tired. And then there's, increase in purposelessness, physical activity. So you might see like inability to sit still, pacing, fidgeting, hand wringing. I mean, basically, you just can't sit still anymore. So we see that in PTSD with the, like that activation that we have in the body, and then in just like any way to try and avoid what we're avoid feeling what's unpleasant, um, feeling worthless or guilty. That again, that's a similar symptom in PTSD, particularly like the guilty piece. But there is a lot of that worthlessness when you experience PTSD, because PTSD interferes in your ability to do the job. And when you can't do the job, then that's where you feel that you're worthless, or you start to feel like you don't have purpose. And so anything that gets in the way of being able to do the job in a way that you feel competent is going to contribute to that sense of worthlessness. And difficulty thinking, concentrating, or making decisions. Well, we just like said, there it is. It's in depression. It's in PTSD. And then thoughts of death or suicide. That's present. It's not explicitly stated in PTSD, but it's like the job is one where you see death, and maybe you make jokes about death. And then we know from everything that has been talked about, and the data that's been collected by Jeff Dill and the Firefighter Behavioral Health Alliance, we know that suicide is a huge problem in the fire service. And so it's like pretty much every symptom that is in depression is present in some way with PTSD. And so if somebody comes in with PTSD and the person they're seeing is not familiar with the fire service, and they're not, expert in trauma and PTSD, they're going to diagnose the person with depression. And then they might throw in anxiety because of the hyperarousal and reactivity piece of PTSD. So, it's like, so we're seeing people get diagnosed with depression when they really have PTSD. And it's not like I want to like diagnose everybody with PTSD. I mean, I think that people do experience depression, and it might be something that is more of a I don't know, maybe it falls under more of like an adjustment disorder or an acute stress disorder. Something where they're just having a hard time dealing with some what happened, and so they're having some symptoms that are difficult to manage. And it's like that's when we would like to see people, but we also want people to be educated that it's normal to have a stress reaction. When you experience a traumatic stressor, you will have a stress reaction. And so a lot of the things that are present as symptoms in PTSD, you will experience at some level, but it will come, you will experience, and then they will go away. And a lot of people at any one time may have met criteria for PTSD, but it resolved on its own over time. And that's not to say that there's no residual of it. There might be some, but it's not meeting full criteria, and it's not disrupting their life. So we talked about that. We talked about depression, and then just looking at anxiety. I mean, most often we see in people, we'll see like a general anxiety. Sometimes people have like social anxiety, where it's difficult for them to be around other people, and they can, they'll do everything they can to avoid it, or they'll get tongue tied if they're out among people. They don't know what to say. They might start sweating. Sometimes people have uh, phobias of things, that specific phobias that can be interfering. So, like fear of flying, or fear of spiders, fear of snakes. If you fear of the outdoors, I mean, if you have those fears, and they interfere in your functioning in, your personal life, school, work, something like that, then you might get diagnosed with that specific phobia. But you can have a fear or a phobia, and it doesn't disrupt what you do. So it's like, I have a fear of spiders, or not so much now. Having a seizure, I don't know why, but it changed my brain. So I'm not afraid of spiders anymore. I don't necessarily like them. They can still surprise me. But yeah, I mean, having that fear of spiders, it didn't make me stop doing things. Like, I didn't avoid like being outdoors in the trees. I am surrounded by trees. There are so many spiders. Um, we we have an understanding. They stay outside, and I kill any of them that come inside. But it's like, that fear doesn't restrict what I do. So if you have a fear and it restricts your life, then it's possible you would be diagnosed with that particular phobia. Um, so with now I was talking about anxiety. So anxiety, you're going to have this uh, rapid heart rate. I mean, so it's like a lot of the stuff that you experience with PTSD, definitely you're going to see in generalized anxiety disorder. So you're going to have, rapid heart rate. You may feel like your heart's pounding out of your chest. You may sweat. You may like find that you're trembling or shaking. And that is like an after response to like getting a dump of adrenaline. So like when you are faced with something life threatening, like you would during the course of your job, then you're going to get that activation of your alarm system, your fight flight system. And so you may find that you're trembling or shaking after you do whatever it is you're supposed to do, you may find that you're shaking. And this would be part of, like of an anxiety disorder, or like moving into panic disorder. Anybody's had a panic attack. So there's a lot of like worry and tension, and a lot of physical symptoms, like the heart rate increase, the sweating, the shaking, feeling restless. So being fidgety, not being able to sit still. This is what we talked about with PTSD. Feeling on edge, easily fatigued, difficulty concentrating, problem sleeping. It's like, these are all symptoms that you see with PTSD. And then, like if we move more towards like a panic disorder. So I know many people have experienced a panic attack. In the fire service, it's like, I'm sure you can think about the many calls that you've gone on because somebody called thinking they were having a heart attack, but really it was a panic attack. So that, same thing, that, I mean, it's like this increase in heart rate, the sweating, the trembling, feeling short of breath, and maybe breathing fast and shallow, experiencing chest pain, feeling dizzy or lightheaded, feeling of choking, having numbness or tingling, maybe chills or hot flashes, nausea or abdominal pain, feeling detached, fear of losing control, fear of dying. And it's like these are all present at some level in PTSD. So you can see why someone might diagnose an anxiety or a depression and not PTSD. And I've interacted with many mental health professionals that are comfortable with diagnosing depression and anxiety and ADHD and adjustment disorder, but they won't diagnose PTSD. And rather than refer the person to someone who would diagnose it, they go with a diagnosis of depression and anxiety. And so then down the road, you may come across an issue where now you've been identified as experiencing PTSD, and you may have filed a worker comp claim, because in Washington state, PTSD is presumptive for first responders that have been in 10 years and over. So it means that now you might have to work a little harder to support the diagnosis of PTSD. So it could be a problem. So what can you do about it? Recognizing that when you go to get help, it is probably at a point where you are really feeling the symptoms, and you're probably really affected cognitively. You may not be the best advocate for yourself, and this information, you may have it tucked away somewhere, but you may not be able to access it. But I'm hoping that rather than get that bad, you will seek help before that. So for you, one of the biggest things to know about all this is there's a lot of overlap. I didn't even really talk about ADHD. I will mention that in a second. I'm gonna kind of tie the anxiety, depression, and PTSD up first before I talk about ADHD and the overlap. With the three, there's the overlap. It's commonly misdiagnosed, and what you need to know is that yes, there is that overlap, but the biggest distinction is for every disorder that can be diagnosed, like one of the criteria at the bottom of all of it is like one is it has to disrupt your life in two or more areas. So it's like work and home. And because if it doesn't, then you wouldn't necessarily get diagnosed. The other is that it can't be better explained by another disorder. And this is where other providers may fail, is that they don't think about that last one. And so if you present to a mental health professional or your general practitioner or whoever it is, and you have these symptoms of depression and anxiety, then they need to ask you, where do you work? And if they know, then they need to ask you, have you experienced any traumas? It's like that, because that's the piece that often is missed. So if you present with depression and anxiety symptoms and you've experienced a multitude of traumas, either it's happened to you or it's part of your job, then in all likelihood, what you're experiencing is PTSD. And it is that experience, and it's that exposure to a traumatic stress. That is the biggest difference between PTSD, anxiety, and depression. And so if you have the depression and anxiety symptoms and the trauma, then it is more likely that you are experiencing PTSD. And if your provider is not, I want to say like not well versed in this, then they will likely not diagnose you with PTSD. And it may be that they're not comfortable doing it, and it's like, well, that's fine. If you have a lot of stuff going on and you're developing symptoms of anxiety and depression, then it would be better for them to diagnose you with an adjustment disorder. Because an adjustment disorder is meant to be short term. It's like you're exposed to something, you've experienced something, something's changed, and you can't deal with it. And so you can see these symptoms of anxiety and depression in that attempt to adjust to whatever that change is. And so if your provider diagnosed you with adjustment disorder, then the understanding is that it is a somewhat short term. So it's generally, the expectation is that adjustment disorder would last for 6 months. It can last longer if there are like a continually changing, like if it's a dynamic situation, then you might see adjustment disorder be like more of a longer term diagnosis. But it's not necessarily an appropriate diagnosis when PTSD would be, but it's one that we expect to see change. And so if they were going to diagnose you with anything, which if you're using insurance, they're required to diagnose you, then adjustment disorder would be the one. I mean, if they suspect PTSD, but they're not comfortable making that diagnosis, then they can put down adjustment disorder with mixed depression and anxiety. And that would fit. And it won't derail your attempts down the road at getting, at filing a claim and having it accepted. But I would rather see people actually diagnose what's appropriate and treat it appropriately. So then I think the last thing was just kind of like the overlap with like ADHD. Now, you might be going, well, ADHD is really no big deal, but it really is. ADHD is very disruptive to an individual's life. And people with ADHD tend to gravitate towards certain fields. And one of them is the fire service. And that is because it has some structure, but it's not the 9 to 5. It has some excitement, and then it's got some, like mundane, boring things. But it's like even the calls that might be the same, it's like there's still a difference. So I mean, there's this constantly changing stimuli. So there's a lot of variability there, and it can be exciting and it can be boring. I mean, it can be a lot of things, and that's something that appeals to the ADHD brain. So a lot of times, and I've seen this. So well, let me tell you if you're not familiar with ADHD. So it's ADHD, and then we specify whether it's inattentive or hyperactive or combined. And a lot of the symptoms with ADHD look a lot like what you might see with like anxiety, and maybe some, and then some of the things that you see with depression, because ADHD can make an individual feel different, and they can make mistakes which then might contribute to them being like perfectionist. So you might see somebody that you would say is like type A, and type A doesn't mean you don't have ADHD. It might mean you do. It's that you've like just adapted. But it's it definitely affects your ability to think. So, like your memory, making decisions, planning, organization. I mean, that's just kind of the base part of ADHD, and then there can be like some hyperactive components where you're, like it could be like cognitively, where you have trouble concentrating on any one thing, and you jump from thing to thing to thing. Um, it might be that you can't sit still. And so you're always fidgeting or hand wringing. Where have we heard that before? Um, or always playing with a pin, or always moving your feet, or it's like you can't sit still. Uh, there's on the assessment that they often use for ADHD, there's a question on there that is like how often do you feel like you're driven by a motor? And people are like, I don't feel that way. Well, it's like pretty much every firefighter I've ever talked to that is struggling with PTSD, that would be something that they describe, because they can't sit still. They have to be doing something. Part of that is the brain's attempt to distract you from what you're experiencing. Some of it can be, you consciously choose that. Some of it is you're just driven to do that. And so that one is often, it's a symptom that could be ADHD, but it's a symptom that could be PTSD. And so there are a lot of times where somebody gets diagnosed with PTSD because they have all these symptoms that actually meet criteria for ADHD, and then they have the trauma piece. And then they might also experience depression, because that also is present in some way with ADHD, and it's not so much a symptom, but like a side effect of having the symptom. And so, and it's possible that you can have both. So having one disorder doesn't mean you are immune from developing anything else. So it is, all these things can be comorbid, meaning they can exist together. It's just that PTSD is often not diagnosed because, for whatever reason, people don't feel comfortable diagnosing it. It is also possible that it might be overdiagnosed, as far as like meeting full criteria of the disorder. I would say that a very high percentage of firefighters experience some of these symptoms. The number of firefighters that may actually meet criteria, I don't know. The numbers are all over the place for that. It's like, I think I have read some research that has put it as low as 4%, and then I've seen some that's been over 50%. But I would agree that over 50% have experienced some symptoms, and they may have some persistent symptoms. I tend to believe that the number that meet full criteria is lower, maybe more than 4%. But I think it's on the low side, because I believe that firefighters in general are quite resilient. And that is why I do this, because I want people to be educated a little bit. I want you to have an awareness. I want people to come get help when they're struggling a little bit, Or better yet, if they want to come and get a baseline and like make sure that they have adequate coping strategies. And I do believe that most people that come into the fire service have adequate coping strategies. It's just that if you keep doing the same thing as you're exposed to different things, eventually those can be overwhelmed. And you need to have more. You need to have more tools. And so, coming in to learn, like, what else can I do? Or learning how to process things, being okay processing things. It's okay to shut, and I don't know if I want to say it this way, but it's okay to be on a call and kind of shut down emotions. As like most firefighters will say, they compartmentalize. So that's okay. But you have to take it out and look at it when you're done and process what it is, because you need to be able to incorporate that experience into all your other experiences so that it is useful for you for the next experience. And anything that you compartmentalize and don't go back to, it is not going to be stored appropriately. And so it's important to come back to it and look at it and acknowledge it. Acknowledge whatever negative thought might go with it. Acknowledge whatever emotion you might feel with it. Acknowledge how it makes you feel in your body. If you can do that, then there's a good chance that you will never develop PTSD. It's not a guarantee that you won't. Everybody carries a lot of other stuff with them. But being able to face it and sit with that uncomfortableness and to learn from it, it goes a long way. So it's not so much what happened to you, but what you do with it. So that kind of goes back to that. And I feel like I wanted to say more about ADHD. It's just that I've seen a lot of people misdiagnosed. I've seen it missed. I've seen it. They've been told that they don't have it. It's like, if it doesn't get diagnosed in childhood, then a lot of doctors won't diagnose it in adulthood, because they look at it like, well, if you really had it, you would have had it when you were a child. But it's like, that's not true. It's like, you may have had it as a child, and for whatever reason, it wasn't picked up. And then as an adult, it's not that you suddenly developed it. It's that you are now under a lot more stress and having to use a lot more of your resources. And it means that then the symptoms that you experienced when you were a child, and maybe you were able to adapt and find a way to work with whatever was coming up. And now it's coming up and you can't do anything about it. So it's like your resources are overwhelmed. I recently had somebody that I diagnosed with PTSD and with ADHD. And while I understand that PTSD can have some very severe cognitive symptoms, or some severe cognitive dysfunction that comes along with it, there was like a pattern of cognitive dysfunction that really sounded a lot like ADHD. And when I asked about childhood, it fit. So that is something to know about that, is that if you did not have any symptoms present when you were a child, you don't have it now. And you may not know, like, well, what would that have looked like? So I listen for and ask questions about, well, how did somebody do in school? Some very smart people can have ADHD and they can do well in school, but they may say, well, I got really good grades, and I worked really hard. Well, that is an indicator of like, maybe I want to ask more questions. And then I will ask more about like, well, what was their favorite topic? Like, what did they do really well in and it felt like they didn't have to work? And what did they struggle with and they had to work? Because with ADHD, there's always going to be something that you like. And when you like it, you're going to focus on it. So they may tell me like, oh, I was really good at math. It came easy, but it's like, reading, that was kind of hard. Or, yeah, I really didn't like physics or whatever it was. They may say that there was something that they struggled with. The other thing is like they may get comments on their report card and they may remember that they got comments like not working to potential. Um, they may remember just flat out being called lazy. They may remember themselves making comments of like, why does everything come easy to everybody else and I have to work so hard? There may be comments of talks excessively, doesn't stay in seat. So it's like they may not remember like what they were like in grade school, but they will likely remember some comments that was made when they were younger. And all those comments that I just shared, it's like if you remember hearing those when you were a kid, then in all likelihood you had ADHD. And so like what you present with now um, fits with ADHD and with the presence of those comments as a child, then that means that you likely are experiencing ADHD and you're experiencing now because your resources are overwhelmed. And so now you're having to work a lot harder. And so you may have some of the cognitive deficits that come along with PTSD or depression or anxiety. Um, but it's like more. Um, so, uh, so that it may mean that you don't get the diagnosis of ADHD because you are struggling with these other disorders. Or you may not get diagnosed with these other disorders because the ADHD gets focused on. But again, it's like PTSD stands out from all of them because it has that exposure to trauma. Um, the last thing that I'll say about ADHD, because this is something that came up, and it's something that I've learned over the years as I've dealt with my own ADHD and as I've learned about it. A lot of times, someone with ADHD will experience depression, for instance, or anxiety, and a lot of it has to do with ADHD and how it interferes in um, our success, um, feeling part of, because you can very much feel like you're disconnected, which is also something that you see in PTSD and depression. Um, but it's like you're not part of, I mean, because you think a little bit differently. I think a good way to look at it is I use a MacBook, and the ADHD brain is like a MacBook, and then everybody else around is a PC. And most people expect you to operate like a PC, and a MacBook does not. It is a little different. It does the same things, it just does it differently. You can't run, like Microsoft software on your Mac unless it has been specifically made to run on your Mac. You can partition your Mac and run a PC operating system on half of it, but that takes up a lot of room. It uses a lot of energy, and it's not as efficient as like operating as a PC if you're a PC, or operating as a Mac if you're a Mac. Um, so, so it's like what that all means is you could feel very different, and And so when you finally get to that point where you can get diagnosed, you may be struggling with depression. So I've seen a lot of people go to get help for depression when their depression was caused because of the ADHD. And this is like where this really came up, is that the individual that I referred, they found a doctor that, you know, he talked to about the PTSD and the depression and the ADHD. And the thing that he was struggling with the most was the cognitive pieces as it related to ADHD. Um, and so the doctor wanted him to get treated for the depression. And the doctor wanted to treat the depression for a little while and see if the cognitive symptoms improved. And they might have, but it wasn't going to solve the problem. So a lot of times it's appropriate to treat the ADHD first. And if you treat the ADHD, then the depression may go away, because the depression may be the result of having the ADHD. And so it's like knowing what it is and being able to parse it out and recognize what is different in each one. And sometimes the difference isn't huge and not glaring. But the one thing about PTSD is it has the trauma. And if somebody says that you have depression and you have anxiety and they ignore PTSD, then they're not diagnosing you appropriately. Because if you have depression and anxiety and you're a firefighter, you more than likely meet criteria for PTSD. And that would be the better diagnosis. And it will get you the treatment that is appropriate for that. And then if ADHD ends up in the mix, it can look a lot like all those other ones. And the way you distinguish the ADHD is by looking back at your childhood and how you were in school, basically. There's like no blood test for it. There's no real assessment for it. It's it's a self-report inventory and then a history. And that is really true of the other ones as well. It is a history and the presentation. So if you find that you're struggling, then if you're struggling even a little bit, then get help sooner than later. I would rather work, well, I shouldn't say it that way, but it's like, it's nice to work with someone who is experiencing some of the symptoms of PTSD, like they're more that acute stress reaction symptoms. And maybe they are experiencing some depression because of that, because when there are changes that we can't deal with, or we're having difficulty dealing with, and we're tired on top of that, then that feels like depression to a lot of people. And it's identified as depression by a lot of providers and practitioners. So it's important. I think it's important, regardless, to get in and get help, and hopefully you will know enough where you can kind of help your provider understand where you're coming from and what is contributing to the symptoms you're experiencing, so that you can be appropriately treated. And I think that's it. Hopefully this was helpful and it made sense. I mean, this kind of came about because of several conversations this week. So I'm hoping that it helps a little bit, and that you will be able to advocate for yourself when you need to, and that you will get help sooner than later. None of this means that you're weak. People go to great lengths to not face this stuff because they don't like the way it feels. And there's often a fear that if you face it, you're not going to be able to deal with it. And I'm like, if it is so powerful that you can't deal with it, then it's like, how does that make you weak when you admit it and you deal with it? It takes a lot of strength to face it. If it was easy, everybody would, well, I probably wouldn't be here. If it was easy, everybody would have figured it out, and I wouldn't be needed. So, um, if you need help, you can always reach out to me and ask questions, um, and or find somebody close to you that you can talk to and kind of bounce things off of. Talk to the person that you work with. Talk to your significant other. Um, you know, don't be afraid of facing and acknowledging what you're experiencing. Everybody experiences something like this to some degree. So I guess that's it for tonight. So I think this was probably a long one, and I apologize for that. And I hope that you found it useful, and have a great night or a great day whenever you happen to watch this. So take care.